And now allow me to introduce Dr. Craig Shimasaki. Dr. Shimasaki received his BS in biochemistry from the University of California at Davis, his PhD in molecular biology and biotechnology from the University of Tulsa, and his MBA at Western University Kellogg School of Business. He is an adjunct professor at the University of Oklahoma and is the co-founder and CEO of Moleculera Labs, a neuroimmunology precision medicine company focused on identifying the underlying roots of neurologic, psychiatric, and behavioral disorders triggered by an autoimmune response. He has spent over 35 years working in the fields of molecular biology, viral pathogenesis, and infection-triggered autoimmune neuropsychiatric disorders. Dr. Shimasaki started his career at Genentech and has worked across all stages of research, development, clinical trials, and regulatory approval of technology innovation from bench to bedside. His research work includes epitope mapping of HIV proteins, genetic-based predictors of breast cancer risk, influenza and RSV diagnostics and therapeutics, and the pathogenesis of infection-triggered neuropsychiatric disorders. He has co-founded multiple companies and led multiple products through the FDA approval process and is co-inventor on multiple patents. Internationally, he teaches and mentors scientists, physicians, and biotech leaders on how to translate their research into acutely needed medical intervention. Dr. Shimasaki's passion is to translate scientific discoveries into acutely needed products so that more patients can live longer and healthier lives. So, Dr. Shimasaki, the floor is yours. Thank you.
Thank you, Amy. It's a pleasure to be here today and to share some, I hope, useful and important information that you might find relevant to your practice. And if we have patients here, or doctors rather, in the UK, we have our partner, I believe, who may be on AONM. So I would like to share a little bit about some biology and a little bit about the immunology, but then also go through specifics about symptoms for these patients, what these antineuronal antibodies actually do, and then some parts of what treatment modalities have been helpful in taking care of many of these patients. So I'm trusting that you can hear me. Amy, everything there, you can see everything and hear me?
Yes, everything is go.
All right, good. So what we'll talk about is chronically ill patients and this connection between infections, the immune system in the brain, and then using this antineuronal antibody panel we call the Cunningham Panel in your practice, and how you can identify patients, how it can help in treatment. So there's 4 topics we'll cover. First is, how really can infections trigger an autoimmune dysfunction that will result and can result in these various neurologic, psychiatric, and behavioral symptoms? And then why certain infections will be a tendency to be present in these patients that have these immune-mediated neuropsychiatric disorders. We'll briefly talk about PANDAS, PANS, neurologic Lyme, and long COVID, but this applies really as a medical model to many other disorders that may be related and have common underlying root. Then we'll talk about how the biological targets in our autoimmune encephalitis panel, which we call the Cunningham Panel, can help diagnose and direct therapy to these patients. And then what are the common patient symptoms, and then therapeutic modalities or the categories that actually show clinical effectiveness in treating these immune-mediated disorders that are really secondary to infection. So with that, let me just share with you what the problem is. Worldwide, there are over 800 million individuals who suffer from some form of neurologic, psychiatric, and behavioral disorders. They have a variety of different tags, labels, nomenclature, and many of them are common that people understand and see. And The important thing to remember about these are that these, including mental disorders, neuropsychiatric behavioral disorders, they are labels and they are diagnosed exclusively on a clinical presentation of symptoms and not the biology of the underlying etiology. And yet they're typically treated symptomatically and they have varied responses to treatment. The other important thing is these labels tend to stay with an individual for a lifetime. So you can see how important diagnosis is. Proper diagnosis is very important because the standard of care for neuropsychiatric disorder today focuses on treating symptoms and in some cases really coping. That includes various types of psychotropic drugs, psychotherapy, and even institutionalization. So this is how it's commonly addressed. Yet we also do know that along with many of these medications, there is a black box warnings for many of them that have to do with suicidal ideation. And in many of the patients we talk about, and we're going to talk about, these infection-triggered disorders already are triggering, in many cases, suicidal ideation. So the question really comes back to, can infections really trigger neuropsychiatric disorders? This is an article that was published in JAMA Psychiatry, and it was based on over 1 million individuals who were followed in Denmark from birth to age 18. And what they found was that if one of these individuals were hospitalized during that period of time for a severe infection, that the risk of developing mental disorders increased by more than 80%. And these diagnoses included schizophrenia, autism, OCD, ADD, ADHD, oppositional defiant disorder, tic disorder, personality behavioral disorders. So this comment from the editors of this journal said, how could exposure to infections affect the brain mechanistically and give rise to mental disorders? They said circulating autoantibodies that enter the brain via a compromised blood-brain barrier and bind to neurotransmitter receptors is a potential explanation, and this mechanism has been proposed in PANDAS and other mental disorders. We're going to talk about PANDAS a bit because it is a medical model, we believe, for many of these other disorders that can be have common root, but also be treated very identically in these different types of conditions. One other aspect that's important is that these infection-triggered autoimmune disorders are not new. So this is not something that's been just recently discovered. In fact, you go back into the 1800s and even to the 1600s. In the 1800s, Sir William Osler described what he called these bizarre percipitive behaviors in children, which called chorea minor, that included obsessive compulsive disorders and was associated with Sydenham's chorea. We do know that Sydenham's chorea is also the neurologic manifestation of an infection and acute rheumatic fever, in which these antibodies that are triggered by the strep bacteria have different targets. In the case of the heart, it's rheumatic fever. In the case of the brain, Sydenham chorea. Back in the early days, it was also known as St. Vitus's dance, and principally because these choreiform type movements and these loss of fine motor control and even emotional control. Another factor is that, as you can see over time, science and medicine is discovering new and previously unidentified neuronal autoantibodies. And these are just antibodies that are attacking different parts of the brain, the central nervous system. And many of these you might be familiar with, those that are associated with lupus and MS, GAD65, NMDAR receptor. This is the patient that wrote a book called Brain on Fire. And these types of autoantibodies are directed against specific parts of the brain and the nervous system. So if we look at how does this occur mechanistically, Well, everybody gets infections. We get various types of bacteria, viral, fungal type infections over our lifetime. But then our body recognizes these and produces antibodies that will not only bind to them and ultimately eradicate them, but also creates immune memory so that later, if it sees something similar, we'll be able to quickly respond. Whereas in certain patients, antibodies that are made in those patients, they cross-react with neurologic receptors in a process we call molecular mimicry, which I'll go over very briefly as to how that happens and what types of disorders are actually associated with this. So in these cases, they're directed against different targets in the brain, as you saw in the JAMA Psychiatry article. We might think of this as friendly fire in the wartime, where these different types of antibodies actually are interfering with various targets in the pre and the postsynaptic neurons in the brain. This results in various types of neuropsychiatric symptoms, with a variety of those can be anxiety, aggression, rage, many of them listed before. And typically patients will be treated with these symptomatic treatments because the biology is not necessarily the first thing that's looked at. And one of the things is that these patients do not respond to these psychiatric medications. In fact, they are typically treatment resistant, and in many cases, they do get worse. Interestingly, SARS-CoV-2 or COVID-19 has shown us that another infection can trigger antibodies in the immune system and T cells and B cells that will cross-react with other parts of the body, including the heart and other parts of the organs in the body, creating myocarditis, cardiovascular problems, chronic fatigue, various things that look like some of these conditions that we've described. So really, autoimmune dysfunction can be and may be in the root of many chronic disorders. Underlying this is an autoimmune encephalopathy that starts from an infection, parts of epilepsy, psychosis, schizophrenia, autism, narcolepsy, chronic depressive disorders, and many more, including PANDAS and PANS. So the goal of precision medicine, though, which is the era of medicine that will actually wants to identify and diagnose the patients who would respond to these anti-inflammatory, immune modulatory, or anti-infective therapy. The idea is to identify these patients, separate them, treat them differently so that they can respond and recover quickly rather than being placed on potentially a lifetime or decades of symptomatic treatment that don't work. At Moleculera Labs, we are also working with the machine learning to predict treatment algorithms that we can identify from about 15,000 patients that we have so far tested since we have been in operation. There's been also a study of children with OCD and tics that have been associated with streptococcal infections and brain inflammation in MRI. We see that the basal ganglia is responsible for voluntary motor control, procedural learning, cognitive functions, emotional functions, and eye movement. And you can see elevated levels in the caudate, which is part of the basal ganglia, the putamen, and the globus pallidus from normal patients, and no change in the thalamus, which is not part of the basal ganglia. So nomenclature can be confusing, but it's not limited to PANDAS and PANS. So if you're familiar with PANDAS, it actually refers to pediatric autoimmune neuropsychiatric disorder associated with a streptococcal infection. We also now know that many other organisms, such as Lyme, Mycoplasma, Babesia, Bartonella, and other viruses, can trigger a similar symptom. And then also there has been some understanding that potentially environmental or other biological factors can also create these similar types of disorders. So you've got both infectious and non-infectious triggers, which is really the reason that the term PANS was coined. And that was around 2015, 2017, that pediatric acute onset neuropsychiatric syndrome was coined, which is agnostic to the infection, which in PANDAS, the S is strep, Whereas if you don't have strep, you really couldn't have PANDAS because it's not strep related. So PANS was coined. There are other terms that are also being coined, like ANDL, autoimmune neuropsychiatric disorder associated with Lyme, or sometimes the A is referred to adults because the P in PANS and PANDAS refers to pediatric. In reality, what we're looking at is this autoimmune encephalopathy secondary to infection or a basal ganglia encephalitis, which really is an immune dysfunction that will result in neuropsychiatric and behavioral symptoms that are triggered by an infection. So patients who are adults won't be able to be diagnosed with PANDAS, but it does not mean that they are not suffering from a disorder that has a similar biological mechanism. So just sort of put this in context, there are other immune-mediated disorders that we don't really discount or don't really think too much about. Rheumatoid arthritis, in which the antibodies and the immune system are attacking the joints and the cartilage and cause inflammation and swelling. Diabetes type 1, where the immune system attacks the insulin-producing cells in the pancreas and creates the need to have some type of therapy to overcome this loss of insulin-producing cells. MS, which is also an immune-mediated system attack in which the immune system, T cells and antibodies attack the myelin sheath around the nerve and create the debilitating neurologic symptoms in the patients. What we're talking about is PANDAS, PANS, portions of autism, ADD, ADHD, schizophrenia, bipolar, and other disorders in which the immune system is just attacking another part of the body. So now let's move to the question of why certain infections tend to be present in patients with these immune-mediated neuropsychiatric disorders. So why would these infections be the ones that tend to show up more frequently than others? And these list here include strep, which is the S for PANDAS, influenza, varicella zoster, mycoplasma, Lyme, Babesia, Bartonella, Coxsackie, and a few others. And they tend to be more frequently associated with these patients. And why might that be? Well, we go back to immunology, and you think about immunology, where our immune system will recognize what we call epitopes. And an epitope is just a string of amino acids in which a particular protein is expressing and the antibodies are recognizing. So antibodies will recognize many epitopes and not just one, but there'll be many epitopes on a particular organism. And what happens then is these antibodies will be generated, but through the B cells, which actually will replicate. There's a T cell involvement, and then memory B cells will be made. This is why we get vaccinated in order to be able to have memory B cells, so that later these same antibodies will be present very quickly if the organism or something very similar to the organism is found. Well, because there are only 20 letters in the protein alphabet that we as humans use, in some sequence, there's going to be an identical string of letters, or in these cases, protein, the peptides that make up a protein. And so let's say that an antibody is made against a part of a particular organism that has a similar sequence. Let's say it's a similar sequence to a neuron. And that particular part or epitope is made to the bacterial part that's identical to a neuron or very similar. What will happen is you will get this cross-reactivity because it's really just looking for a similar target, and that similar target may not necessarily be just the bacteria or the organism. This is what we call molecular mimicry, and it is why we named the company Moleculera Labs in reference to this molecular mimicry. And then autoimmunity really occurs when there's a breakdown of this self-non-self discrimination. We won't go into that today, but the immune system has mechanisms to prevent that. And it's really this self-check to be sure that it does not allow self-reactive autoantibodies into the bloodstream or immune cells that produce these antibodies into the bloodstream. However, in patients, that have autoimmunity or tend to have these types of conditions. What's been understood is these genetic factors that are found continue to be these MHC complexes, the HLA class 1 and class 2, which means that a family history of autoimmunity or immune dysfunction will be typically identified in the majority of these patients or in their family history, and that there's some type of an immune dysfunction. And so molecular mimicry between group A strep can be described as this, where in the case of the group A carbohydrate and the protein, by the way, there's over 100 different M proteins in Streptococcus. So there's a lot of different strains and subtypes. But in this particular one, the M protein, there's parts of it that are very similar to heart valves. Again, this is part of the reason why in some patients you will see the family history of immune dysfunction, but they may end up with rheumatic fever. Now, rheumatic fever is not a huge problem in the United States anymore because of the advent of penicillin, and whereas in other countries it still is. Basal ganglia is another target, and that is what results in Sydenham chorea. Also, some commonality to the joints, which you can see arthralgic pain or arthralgia in some of these patients, kidney dysfunction, etc. So you can see the connection between how the molecular mimicry and how these antibodies that are triggered can create these different types of disorders and symptoms. Really quickly, molecular mimicry has also been identified in what we know as narcolepsy, in which antibodies are made against certain proteins and certain receptors that used for wakefulness and sleep in us, in humans. Interestingly, influenza and in some vaccinations, that there have been particular exposures or expression of more of these common epitopes in which associated with certain vaccinations and even with certain influenza strains, you see more narcolepsy showing up. There is, interestingly, molecular mimicry between Borrelia burgdorferi, Lyme, and strep. And part of this is also one of the reasons you will see and do see what might be termed post-treatment Lyme disease or disorder. And that tends to be associated with various types of additional neuropsychiatric symptoms. So in this journal article, it talked about the sequence homology between Borrelia burgdorferi, outer surface protein A, which is one of the proteins on the outer surface of the Borrelia spirochete, and then also the M protein, which we discussed in strep pyogenes, suggesting a role for molecular mimicry in generating these autoantibodies that are reactive. Briefly, we'll get into, we do tests for antibodies against dopamine D2. And in dopamine D2, you can see here in a sequence comparison, SARS-CoV-2, the open reading frame for one of the polyproteins. You can see the green indicates where there are common letters of the protein alphabet between dopamine D2. And in this case, you can see additional sequence homologies. And therefore, this can be part of the reason why you might see neuropsychiatric symptoms in patients with long COVID, which is basically an immune dysfunction or an immune dysregulation that is triggered by SARS-CoV-2. So simplistically, molecular mimicry is really mistaken identity. In this case, it's the immune system that can distinguish between what's self and what's non-self because they've created antibodies that recognize something that's common to both. So let's now move over to how the biological targets in the Cunningham panel can help diagnose and direct therapy to your patients or those with immune-mediated neuropsychiatric disorders secondary to infection. So really, this is not something that's been quickly identified. In fact, Dr. Cunningham and her lab for over 20 years have been studying Sydenham chorea and the biomarkers and the targets and what we call this cell stimulatory assay. So this is what the report looks like. If you were to order a test, there's 5 different tests that we run. And this information that I'll share here is based upon over 15,000 patients that have been tested. So when antibodies are directed against the dopamine D1 receptor in the brain, we tend to see psychiatric symptoms like mood swings, depression, anxiety, irritability, aggression, and even potentially psychosis can occur. When antibodies are identified that are directed against the dopamine D2 receptor, we tend to see more movement types of disorders. It could be choreiform movement. It could be even maybe a potential diagnosis of ADHD because the patient just couldn't hold still, possibly even Parkinson's type symptoms. When we see antibodies directed against lysoganglioside, this is again the myelin sheath around the nerves. We refer to this as sort of the tic cluster. We do see patients complain of joint and connective tissue pain. And then tubulin, which is an intracellular protein that's highly concentrated in the brain, which is why we use this. And we tend to see OCD very frequently, and patients will complain of things such as brain fog, cognitive functions, even food phobias, intrusive thoughts, things like that. And then this, what we call CAM kinase 2 activity. This is a very specialized cell-based test in which we grow brain cells in culture, not the patient's brain cells, but a cell line that's been propagated. And then we incubate the serum of the patient on these cell lines to see if they will stimulate this enzyme. Well, if they do, you'll see the elevated positive, and we refer to this as an activation of the sympathetic nervous system. So when it's positive or elevated, patients will tend to be presenting with various types of symptoms that include those related to fight or flight behavior. So it's separation anxiety, sensory sensitivities, easily startled, mydriasis. And also what we find over time is that when that's activated or elevated, often there is a subclinical infection that still has not been addressed. So you can talk to us a little bit more about that if you have questions. A few case studies before we move on. We have hundreds of case studies of patients before and after treatment. I'll just show you a couple of them. This is a young man who presented with OCD and tics and then lost 30 pounds. Now, this again is more of a food phobia or a fear of food contamination, referring more to an OCD than an identity issue. And what you can see is the CAM kinase is positive and none other, which is why we run all 5 of these, because we don't know which ones could be positive or would be positive depending on the symptoms. This patient was treated with intravenous immunoglobulin, which is one of the treatments that can be used, but also plasmapheresis due to the symptoms of this patient, and it resulted in complete symptom reduction, and all the antibodies returned to normal. This was a younger girl who had developed autism-like stimming behaviors, OCD, couldn't concentrate, behavioral regression, even bedwetting at 9 years old, dysgraphia where their fine motor skills were not normal. And as you can see here, 2 of these, both the tubulin and the lysoganglioside, were positive and borderline dopamine D1. Interestingly, this patient, I believe, was one that was caught early in the fact that it was a subclinical, I believe it was subclinical strep infection in this patient. They were treated with azithromycin and rapid improvement of all their symptoms, and all their antibodies returned to the normal range. This is one of the things that's important in early detection. Another girl, young girl, who was known to have contracted Lyme and began to having a whole host of neuropsychiatric symptoms. In fact, we have a case study that was published by the doctor there on this. Can see a positive dopamine D1, a positive dopamine D2, a positive antitubulin. And the patient was treated clearly for the underlying Lyme condition, but for the immune system was treated with 3 IVIG treatments and complete symptom regression. All their antibodies went back to normal. This is another young man who presented 30 days after a strep infection, so it was a known strep infection. Presented with OCD and tics, couldn't concentrate, emotional ability. Again, you see many of these similar symptoms: bedwetting, sleep disturbances, dysgraphia. In this case, the one positive, which was the CAM kinase. In the case here, the treatment was 1 IVIG treatment, and within 1 month of diagnosis had complete symptom elimination. Again, it goes without saying the patient would be treated for strep because the infection is what would be the triggering agent. But we do see amazing recoveries from patients that are properly diagnosed and treated, and I think this is the important piece. There's a video on our website for Grace's story. She was diagnosed really at 8 years old with mental disorders and even was trying to kill herself. The mother was videoing this and has since been in contact with us over time and been tested. Her treatment was changed to address the underlying roots. And then more recently, her mother sent us this picture, completely back to normal life and on the cheer team. We love to hear these stories about patients with full recoveries. The sad fact is the financial impact and burden of care on families with these disorders are huge. In fact, we have a study that is being prepared for a manuscript on the burden of these different disorders on patients and families. And what you can see is a very small snippet of some of the various write-ins of what the patients have said about what these disorders have been doing to them. So over 15,000 patients that we have tested, we find that they have seen between 5 and 15 doctors before they've received a proper diagnosis, or they found us, or we've tested, or they've been tested to be positive. Sometimes the time between the symptom onset and the diagnosis is between 3 to 5 years. Sometimes it's even as long as 20. And they approximately 3 to 18 months they go through before ever receiving effective treatment. So this is something that we really, really hope to be able to impact, and that is early detection and the right treatment. So what are some of the common symptoms that are associated with the patients that present with these positive antineuronal antibody testing? What we do see is that they are typically treatment resistant to standard neuropsychiatric drugs. Now, it doesn't mean they don't get treated with them to help in many cases, and usually as what's identified is these are really very, very low dosages, usually of SSRIs. We'll talk later about some of the treatment options, but the frequency of infections can be seen in these patients struggling with multiple infections, but even they can be subclinical, where the patient's not demonstrating that they are ill from a particular infection. So often they will be diagnosed with post-treatment Lyme disease or neurologic Lyme. Again, remembering the molecular mimicry part, that they typically will have a family history of autoimmune disorders, not mental disorders, but autoimmune disorders. Often, but not always, there will be a sudden or rapid onset of symptoms. So meaning maybe within a short period of time, the patient was one way and then they're no longer normal again. That is one of the definitions of PANDAS, PANS, sudden onset. But many of these patients who suffer from these and do have antineuronal antibodies have gradual onsets. They do see sudden onset of OCD. Restrictive eating disorder, again, is another symptom that can be common. Again, this is not an identity disorder. It's a phobia of fear of contamination or choking. They may have motor or vocal tics, choreiform movements, anxiety, rage, depression, developmental regression at an age that was not appropriate. Mydriasis, dilated pupils in a percentage of these patients. Again, these are those we tend to see with a positive CAM kinase. and then the typical relapsing remitting course of these different types of symptoms. One of our neurologists who has probably tested over 1,000 patients will tell you that all of them, if you ask them, experience suicidal ideation, but they don't volunteer the information. Clearly, PANDAS or PANS diagnosis and symptoms. So briefly, I just want to show you a study in which we looked at both before and after treatment of these patients that had either been diagnosed or presumptively diagnosed with PANDAS or PANS. But remembering again, PANDAS and PANS is a medical model for many of these different types of disorders. So we had patients in group 1 and group 2, and group 2 was those that did not get better after a certain type of treatment. And this is a future study of what those treatments were. But they all had either strep or multiple infections, and various those you can see that I mentioned in the previous slide about these common infections. But this is one thing that is typically seen in these patients. They also had very similar symptoms in group 1 that got well after treatment, and group 2 that did not. Decreased concentration, OCD, emotional abilities, sensory symptoms. Again, the entire list, and you can see high percentages of all of these. So what we found is for the group 1, before they were received treatment, you can see every one of them had one or more positive autoantibody presentation, including, in this case, D1, whether D2, tubulin, lysoganglioside, or CAM kinase. After treatment, those that improved or completely resolved, you can see the dramatic change in the presence of their antineuronal antibodies. What we found is that that gave us a sensitivity of 88%, a specificity of 83%, overall accuracy of 86%. We're working with machine learning to actually allocate different weights to these tests. We can get the accuracy up to at least 90%. And again, you can see the difference before and after in successful treatment. And so, and this is just a slide from the previous there. There are multiple published research articles that if you're interested, we certainly can send to you. Also on our website about patients that may have had, in some cases, schizophrenia, Lyme disease, autism, and responding to various treatments after being positive. So here's a brief overview of the testing and process. If you're a clinician or provider or a physician taking care of a patient that may have these types of symptoms, we have a deposit, and the panel is $9.95. And then once we receive that, that comes to us by FedEx. And then we will test against these 5 brain targets and review, and then these will be sent to the provider. And then as a courtesy, we bill patients' medical insurance, and then they will provide it back to the physician, and we have consultation available. So what are the therapeutic categories that have shown to be effective? One of the things I'll recommend is the PANDAS PPN. Again, remembering this is for PANDAS, and it's they have gone to a great deal of work trying to give a diagnostic protocol and flowchart. And one of the things that our panel is useful for, and it can be, is to help in the aid of the diagnosis. Again, this is not a diagnostic for PANDAS or PANS, but it is an aid in a diagnosis by the clinician. The treatment guidelines do outline certain cases for mild, moderate, or treatment or extreme cases. And you can also find this in the Journal of Psychopharmacology, or Child and Adolescent Psychopharmacology. So the overview for the treatment in this case is that first you have to identify and treat all the infections. Next is to provide symptomatic relief, because sometimes patients really do need some type of symptomatic relief because they can be maybe dangerously close to different types of things that could harm themselves or others. Treating the inflammation and treating the immune dysregulation. A couple of articles that you can find also showing the effectiveness of antibiotic treatment. In this case, Septinar compared to a placebo in the case of motor tics and vocal tics. So what this is looking at the Yale Global Tic Severity Scale and the decrease of that using an antibiotic as opposed to a placebo, and the overall improvement in the score. One of the other treatments it can be is immune modulatory treatments such as IVIG and plasma exchange. This is one published in the Lancet. And you can see in this case, there was one treatment, and within 1 month, the drop between the L. Brown Obsessive Compulsive Disorder Scale for IVIG, placebo, and plasma exchange. So you can see the improvement, but basically these therapies are removing the immunoglobulins, or in the case of the IVIG, it's potentially that they are actually causing a feedback loop to downregulate the production of antibodies. Another article and study of 21 patients looked at with intravenous immunoglobulin at 1 gram per kilo, 21 days, every 21 days, and 6 infusion cycles. They were measured for various types of psychometric assessments, and 50% improvement within at least 8 weeks. And you can see the dramatic changes in the improvement scores. And this is another indication of an immune modulatory treatment being helpful for these patients. One that some of the physicians use is rituximab. Again, these are things that are important to be done in the context of really recognizing and monitoring patients. But again, speaking to the immune system involvement, rituximab, though its original use was for a cancer drug, it targets, these are monoclonal antibodies that target the CD20, was the cell surface receptor for B cells. And by doing that, the rituximab antibody identifies, binds to them, and then the normal immune system through phagocytosis, complement activation, and the killer cells remove the B cells. And then the B cells are repopulated again, and those that had autoimmunity are potentially gone. So clinical effectiveness has been demonstrated when there's biological evidence of autoimmune inflammatory disorder, and they fall into these different areas: anti-infectives, anti-inflammatory, immune modulator, and temporary symptomatic treatments. So there are a lot of different allopathic, naturopathic drugs and compounds that fall into these areas. And I believe that there are many that we don't know of yet that can fall into these categories that can be utilized. Currently, many of those that are allopathic are known to be used, such as steroids, NSAIDs. I mentioned plasmapheresis and IVIG and rituximab, but there are others, and I think that's an important aspect to realize if they fall into those categories. So JCAP, the Journal of Child and Adolescent Psychopharmacology, has a series of articles that go through different case management syndromes of patients with PANDAS, and particularly remembering PANDAS being a medical model. So one thing that you might look at if you not familiar with PANDAS, or really the effect and the impact, is this YouTube video, and it's on DVD. It's called My Kid Is Not Crazy, which Tim Sorrell produced, and it was a documentary that chronicled the lives of these several children and their families who are suffering from PANDAS and PANS, and you can watch it for free on YouTube. So the important is to identify the underlying root. I'm going to end with what I adapted from Dr. Sidney Baker's TAC law, which if you're sitting on a TAC, the treatment is not 2 Advil for every 3 to 4 hours. TAC treatment for TAC sitting is TAC removal. And really the takeaway is you want to search for the root and treat the cause rather than the symptoms. And then TAC law number 2 is if you're sitting on 2 TACs, removing 1 TAC doesn't eliminate 50% of the symptoms. So because these conditions are complex, you really do need to treat all of the underlying issues. In this case, infection, inflammation, and the immune system. And so we provide free consultative services for those that have patients. You can call our direct line or speak with Amy Cross, our nurse here that is moderating this. And any other questions can be directed to the office. We do have free educational services for in-service and other webinars. We have publications and videos available and other things that you can just download or order, and we can send them to you at no charge. So really want to thank you for being at the front line. I know that there's a lot of information here. The goal is to help you understand how this complex condition or these conditions really are treatable and they are diagnosable. But they do require an understanding of how this does occur and what are the underlying roots. We're here to help you. Again, here's some resources. If you're in the UK, AONM does a great job helping and working with us and educating. If you're not in the UK, you can come directly to us. PANDAS Physician Network is another alternative, and they do have support systems there. So thank you for listening, and I will be available to take questions if you have any.
Thank you, Craig. There are some questions, and I will start with a question from Dr. Thompson, who asked, you're initiating treatment for infection. When do you expect antibodies to go down, and when should you retest? This is a frequently asked question and very important.
Yeah, no, it's a great question. And typically when you are treating an infection for this that's related to the neuropsychiatric disorders, often what we hear is that within a few days, the patients will start improving. What it does mean is that the offending infection is not stimulating as intently the immune system to produce these antibodies. Typically what we do, and we have different groups that test at different stages, is one, if they get to a plateau and the patient doesn't continue to resolve, meaning maybe 50% resolved, they'll retest and see if there's still autoantibodies there. Often also what they'll do is then after the patient is completely well, before they take any treatments or stop treatments, that they will test at another interval just to be sure that there's nothing else there that they need to deal with. The time frame can vary, and typically we advise that you look at based on the symptoms of the patient, because again, this is a metabolic test, meaning that it's a point in time at which we pick up these at which the patient is there. So if you start seeing improvement with the patient and maybe they plateau, that would be a good time to retest. Or if you're interested, and we do many case studies, after the patient is fully recovered and you'd like to see that there's still the antibodies are gone, we have a number of doctors who do that and write up case studies, and we help them. So the time can vary, but it's a great question because it can help know whether or not there's still autoantibodies present.
Thank you. Another question from Dr. Thompson. What is an alternative for IVIG, because we don't know if it's been affected by vaccinated blood supply? That's another frequently asked and important question.
Yeah. So IVIG is really one of those that we really don't know how it works. And again, because it's probably accumulation of thousands of patients who go to these centers and their plasma is collected, really the antibodies are fractionated and then collected. Typically what we do see is that sometimes, and this is not related to the question, but it's something that could be helpful, in some of those preparations, they may have antineuronal antibodies in them. Now, even though it might prolong the recovery, but because it's exogenous rather than a B cell that's producing it in the patient, we still see that IVIG can be effective in helping to do that. Alternatives to IVIG, you saw plasmapheresis, and these tend to be in patients who don't respond to, let's say, anti-inflammatory agents or antibiotics or anything that would deal with the infection. Right now, there aren't any really sort of universal good immune modulatory treatments that could work for these patients, because these that are used, like IVIG, like plasmapheresis, like rituximab, are off-label uses, meaning, they're being used because they do help and they do work, but they have not yet been gotten an indication for that. So going back to the one slide showing that anything within the immune modulatory treatment can be something that you could try and work. And we do have many different groups of physicians and even naturopaths that work with alternative types of medicines or alternative types of treatments. So that might be another seminar or something we could do, because there are very good physicians who have found certain ones work. Again, not everything works for everybody, but if you think about the categories, immune modulation, that's an important area. And I'll just throw one out. Sometimes what we see usage is low-dose naltrexone. Has nothing to do that we know with, but it does have something to do with immune modulation and anti-inflammation. So things that are not advocating any off-label use, we don't practice medicine, but just that other individuals who treat these patients have seen things that have those effects are related to anti-inflammatory or immune modulatory effects.
Thank you. A question from Dr. Robinson. Can you speak to the testing before and after on the group that did not respond to treatment? So Dr. Robinson's referring to our 58 patient case study.
Yeah, no, that's a great question. And I didn't show the slide, but in those patients, what you could see before majority of them had positive antibodies, a few of them did not. The ones that didn't respond to treatment actually had more antibodies, and I think all of them had multiple autoantibodies. So it showed the correlation between symptom improvement and lack of antibodies and symptom either continuance and the presence. What we did not set out to do was to find out what the treatments were. So what we do know is that in many of those patients, they weren't necessarily treated for the underlying root cause. And so another study, which we will hope to be doing, will be one that will focus on treatments. The first one was really, is there a correlation between the symptoms of the patients and their presence of autoantibodies? And is that something that we can count on for showing and addressing treatment? So we don't have a definitive answer on that because it wasn't the original purpose of the study. But what we do see in many cases is they're not addressing the underlying root. They're actually addressing maybe symptoms, or they're trying to do some other things.
I might mention that report that you have for your patient, the 18 or so pages that accompany that report include the study that Dr. Shimasaki referenced and the heat map for the patients who did not recover at the time of the writing of that paper are in that article. And if anyone needs a copy of that, I'd be pleased to send it. Robinson, who says, I had one patient recently test positive on the Cunningham Panel on 2 antibody markers. He had diffuse asymmetrical hypometabolism on PET scanning under anesthesia. The question is, are PETs often done on these patients, and what do they typically show?
There's a whole area of research on imaging for these patients. Unfortunately, it's been challenging because the ability to identify consistent signals or even inflammation. There was that one study that I showed that did that many patients aggregated to show an overall increase in inflammation in the basal ganglia. But typically, there is not any real good imaging techniques to be able to say definitively that these patients are suffering from an immune-mediated neuropsychiatric condition. Now, of course, these other imaging studies are important to rule out other causes now, but to the question, there's a lot of study by different groups, including the Stanford group and some of the other groups at different universities, to look at different types of either functional MRI or other types of PET and other types of CT. But so far, there's not anything yet that can definitively say this is let's say, a brain inflammation in the basal ganglia that's very well defined and you can count on it. But that is something that we do hope will continue to be researched and found out.
Yeah. The physician caring for community and institutionalized patients with intellectual disability and autism, I was surprised to find that the rate of macrocreatine kinase type 1 in my patients with challenging behaviors is right around 40%. Per the literature, this autoantibody complex pairing CK-BB found in nerves and smooth muscle and IG, typically IgA, is found in only about 1 to 2% of the population. And in that general population, the finding matches with autoimmune disorders. Could this be a marker for central nervous system inflammation?
Oh,
I'm glad you're answering that question instead of me.
No, that's a really good question. We don't measure that, but it does make sense that it could be. And if you're interested, would love to talk to you about maybe some studies on that, because really you may be looking at a complex of immune, aggregation or something that's going on in these patients that might be indicative of some type of an autoimmune condition. So I don't have an answer for you, but that's a very interesting question. And immune complexes are seen in long COVID patients because they have this aberrant immune response to various from SARS-CoV-2, but it then targets against whether it's heart or the linings of the blood vessels or something like that. So be happy to talk to you about that. That's interesting because I don't know the answer, but that could be definitely something that kind of relates to all of this immune dysfunction.
Thank you, Dr. Shimasaki. We are out of time, but I would like to thank everyone who participated in the webinar, who registered for the webinar. And Dr. Shimasaki, thank you for yet again another informative onboarding webinar, and I hope everyone has a wonderful pre-Christmas weekend.
Let me make one more comment, Amy, while I was still there, and I think related to Dr. Robinson's comment there is the institutionalization of many of these patients. We do have some studies going on with autism patients and seizure disorders that are resistant to treatment. And we do find that they're positive with autoimmune antibodies. But we also are always very interested in the percentage of patients that are institutions that may really be immune-mediated and that could actually be helped and resolved. So, if there's interest in that too, we would love to participate in trying to help answer that question. And so this is really the interest of us in the company, and what we're working on is how do we help understand better the prevalence of the disorder, how it actually can be addressed and treated properly, and patients can get well faster. So there's interest there. And by the way, Amy, Cross is the manager of our medical relations and is involved in many of the studies that we've got going on, and also speaking to many of you and others. So we have a vast array of different practicing physicians whom we really admire and would like to help support. But I think this is an area that really has an unmet medical need that we'd be happy to work with many and any of you who are interested.
Okay. Well, thank you again, and thank you again to all of our attendees, and to you again, Dr. Shimasaki. Thank you.
Thank you.